Hey doc, it's Nick. We have a pretty interesting case here. Invisalign case. Patient wants to straighten their teeth. As we can see in this photo here, it's going to be a rather complicated case to execute, whether or not we resolve all of the issues, some of the issues, or just a few of the issues. So I'm going to share with the audience here just a little bit about what the patient's looking for. So patient's just looking to straighten their teeth. And before we start talking about solutions, let's take a little bit about diagnosis. Without a question, there's a interarch discrepancy. So there's a transverse discrepancy here where the upper arch is constricted. Posterior crossbite might be another way to describe this. Most likely due to inadequate development of the maxilla. It's pretty obvious here that that's definitely part of the case. As we can see, this isn't a lateral ceph, but we can see here that the mandible is in a more anterior position, sagittally in this direction here, than the maxilla. So skeletal class 3 is most likely a diagnosis. I don't have the ceph here, so it's hard to definitively confirm. With that said, I think we get a pretty good idea what's going on, which leads us to a class 3 dental relationship, both with the molars and the canines on the right side, and then on the left side that also holds true, but I think it's exacerbated by the presence of a retained lower molar. Because primary molars occupy more mesial distal width, whenever we have a retained primary, we're going to have an exaggerated dental sagittal discrepancy. So this will exacerbate the class 3 relationship. Because there's only one here and there's not one on the other side, we would expect to see a midline shift. So I'll typically take a look at that. But oddly enough, the midlines are rather coincident here, which is an interesting observation. I don't think we need to dive into it too much in this particular case. With that said, these are the questions I normally ask because they sometimes reveal things to me that I probably wouldn't have seen otherwise. So to summarize that, whenever I see an asymmetrical situation going on with retained primaries, missing teeth, spacing, I will almost always come and look at the midline and just say, is the midline off to the degree that I wanted? If not, what could explain that difference? And I think the part of it has to do with the fact that the canine and the laterals are transposed, which you had identified, which is rather interesting, not something we see too often. But if we ask the question, why is the midline coincident when we have a sagittal discrepancy between the left and the right side through the retention of this primary molar? And I don't think the answer is super obvious, at least not to me. But I'm going to take a closer look to see what might be leading to that. I'm going to table that for now. I think part of the explanation might be due to the fact that the crowding on the upper left is a little bit more exaggerated than the upper right. But there might be some skeletal aberrations that we can't see here that we should account for. So there's more to the equation here than what we can see on an iTero scan, which is why we really should have ceph tracings, or at least a CT analysis of the skeletal structure. With that said, the patient was very clear to you that she was not interested in orthognathic surgery, was not interested in even non-surgical approaches to expanding the palate, something that we do a fair amount of. Patient just wants to straighten her teeth. So our job is not to perfect every patient and then turn away patients that aren't interested in perfection. Our job is to listen to what the patient's needs and desires are, and then educate them on what the pros and the cons of each treatment plan, what the pros and the cons of each treatment plan are. And that's definitely relevant here. So what I would say is, if the patient's primary concern here is aesthetics, we can definitely do something here, but it's going to be challenging. the likelihood of having unintended consequences of trying to fix this without fixing the skeletal foundation, those risks might be higher than normal. With that said, can we create a plan that's lower risk, but then build the patient's understanding into the treatment plan, meaning educate them on why this is difficult? And what I would say here is unraveling this particular anterior relationship without fixing the posterior transverse relationship is going to be hard. But I did put together a treatment plan that I think will get the patient's needs solved with a low risk final outcome. So another thing that I think about with class 3 cases in particular is the use of IPR. So IPR is a technique that we can use. I typically don't like IPR, especially in class 2 cases. Reason being, I don't like decreasing arch width. So whenever we do IPR, we're decreasing the length of the arch in order to get the teeth to come together better. So the length of the arch can be thought of as a border parameter for the space of the tongue. In other words, the tongue lives in a garage. When we do IPR, we're making that garage perimeter shorter. Therefore, what's in the garage will have less space to live freely. And as we know, airway situations tend to be rather relevant most of the time. With that said, class 3 patients, just based on the fact that their mandible is relatively forward, lends itself to lower risk for airway risk. So I'm more likely to do IPR in class 3 cases because of the fact those are low risk airway situations. With that said, analyze your patient, and if they're at higher risk for airway compromise, then maybe we don't do IPR. But my point here is class 1 and 2, I'm going to try my best to not use IPR where possible. Class 3s, I'm going to be more open to the concept. In this case, I think IPR is a wonderful choice. So, and we'll get to that in a moment. The other thing is I'm often looking at, especially in crossbite situations, I'm asking the question, do I need to try to create mutually protected occlusion? And if that term doesn't immediately put a picture in your mind, I invite you to understand that concept to its fullest degree. Mutually protected occlusion. We have a couple of occlusal videos on the Nikkei channel that talk about it. But in a nutshell, mutually protected occlusion is a quote-unquote ideal occlusion that we should aim for in some patients. Now, I can appreciate that maybe some people in the Pinky and Dawson community will say that mutually protected occlusion is the only occlusion, but there are patients with skeletal abnormalities such as this one where we're just not going to get there. Simply just not going to get there without surgical intervention. So I bring this up because I've developed my own set of ideals, and I love mutually protected occlusion in the patient who would benefit from mutually protected occlusion. And who are those people? Those are people with anterior wear or posterior wear. And I said those separately because they're two different things much of the time. But in a nutshell, when I see a patient who is at low biomechanical risk, meaning I don't see a lot of attrition here, I do see some wear facets, but that's probably more due to the fact that her occlusion is about ready to get an upgrade, and not so much central nervous system mediated bruxism, airway bruxism, things that are external factors that are likely to influence attrition of the teeth. Mutually protected occlusion in those patients might be a more ideal outcome. So to paraphrase, mutually protected occlusion in a high-risk biomechanical patient might be a good idea, or I would say is a good idea to try to explore and try to have that be your endpoint. But in a patient that shows low biomechanical risk, I don't know if mutually protected occlusion is necessarily the endpoint we need to go after. In this patient, that would be rather hard. So I'm going to spend a little bit more time on this, and I'm just going to call it MPO for mutually protected occlusion, so I don't have to keep saying that rather verbose phrase. But MPO is essentially the idea that we want the back teeth to protect the front teeth and the front teeth to protect the back teeth. That's a very Cliff Notes way of saying what are we trying to achieve through MPO. Back teeth protect the front teeth through MIP. In other words, when the back teeth come together, the back teeth burden most of the load in that MIP position. But as soon as we go into lateral excursus and or protrusive movements, the front teeth from canine to canine pick up the contact of the teeth during those dynamic movements, and the posterior teeth disclude. So that's a more kind of refined way of describing MPO. But in patients who have low biomechanical risk, they're probably not spending a whole lot of time grinding their teeth. So to have posterior disclusion, especially in a patient with a posterior crossbite, I don't know if we necessarily need to go to the extent of trying to get these canines to relate to each other in a normal fashion to disclude the posterior teeth. Now, one could easily say surgery would be better, but to achieve those goals, and I wouldn't disagree with that. We have to ask the honest question: does this patient need to go through all of that to achieve that endpoint? I don't know if I have the answer to that, but in a patient who's not interested about it in the beginning, I'm very comfortable doing this more camouflage treatment. Camouflage treatment is a term used in orthodontics that basically says we're going to make this as ideal as possible, make it look as good as possible, but not have it be perfect. So this is 100% what we're going to call a camouflage treatment plan. So back to this MPO conversation. In order to achieve MPO, we would need to get these canines to relate to each other in a much more class 1 relationship. Although they look close here, getting this canine to relate to this canine and this premolar in a more proper orientation is going to result in a rather difficult aesthetic outcome. And what I mean by that is if we take this tooth and we make it relate to number 27 properly, we're going to have to do the same to number 5, to number 4. How do we make this look good without fixing this transverse relationship? That's hard to do. So I guess my point is there's always this trade-off that we're going to have as we're trying to optimize the biomechanics with the aesthetics. So there's an aesthetic trade-off much of the time. Let me just take another little step sideways and say, if we tried to fix this relationship here, the amount of tooth movement that would need to happen on these upper teeth would put the periodontal apparatus at high risk for recession, bony fenestration, instability, so on and so forth. So if we look at it from the side, that's a lot of movement, and this software doesn't really tell you. It can if you click on the tooth movement analysis, but your eye should be, as you start to do more and more clin checks, thinking about the potential periodontal compromise as you start to move teeth towards the buccal surface. So let's just say without surgery or non-surgical palate expansion, I would not try to resolve this alone with Invisalign or clear aligner therapy. Yet could it be done? Potentially, but the risk of the periodontal compromise is pretty high. And since we just established that this patient doesn't need proper posterior relationship per se, why put the patient at risk for that? So you'll see in my treatment plan, I actually locked these teeth in. I made them unmovable. I don't want to introduce potential error of these posterior teeth when we already know these posterior teeth are relating to each other in a somewhat what's the word I'm looking for? Somewhat non-pathologic way, meaning they are there now. We don't see a whole lot of wear. Why are we going to try to move them? And I say not a lot of wear. There is a wear facet here, so there are some things going on, and the patient's young, so maybe there is a slight biomechanical risk here. With that said, the patient made it pretty clear. Posterior teeth movement is not really what she's looking for. So I hope that makes sense. I threw a lot out there, mutually protected occlusion, as a way for us to think through what the ideal is. If we're not going to get there, what are the compromises that are going to be made? If we're not going to get there, what is the trade-off with the aesthetics? So in a nutshell, as I'm thinking about what to do here, there's a lot of diagnostic underpinnings here that we have to think about. So before I talk about what we're going to do, let's review. IPR in a class 3 situation, I'm more likely to do, especially if there's low airway risk. We can look at the Nikkei videos on airway assessment to try to get a sense of are they at risk or not. But let's just assume for the moment that this patient is at low or minimal risk of airway compromise. I'm more likely to do IPR in the lower arch here to achieve that. And I'm going to choose IPR in areas where I'm more likely to have triangular teeth. What do I mean by that? So long flat contacts, I'm less likely to do IPR or program less IPR than contacts that have this more kind of angled appearance. So let's take a look at this side here. Primary teeth, definitely more triangular here, so I'm going to do a lot of IPR around this tooth so that we have nice space gain through the use of a tooth that's probably not going to be there long term. So I'm much more likely to program IPR around a primary tooth. I also have this overly erupted number 12. I'm probably going to idealize this for aesthetics and leave the space here. I'm not going to try to extrude this tooth because the root form underneath it is likely insufficient. Plus, I don't want to activate the cementoclast of the tooth through orthodontic movement and then risk this tooth becoming stabilized. So if this tooth needs to stay for a long time, I'm going to try to keep it where it is. If there's any interocclusal space between the two here, I'm going to restore this with composite. You know, ideally talk about putting an implant in with this patient, but let's just assume for the sake of argument that the patient doesn't want to do that at this time. I'm going to try not to move this tooth much at all. So after all of that, I came up with this plan here. Let's see. Add to comparison. All right. So the gray teeth are the ones that I made unmovable. I add and subtracted teeth in the unmovable status until I got what I wanted. But essentially what I was trying to do was create almost an edge-to-edge anterior relationship. And anytime I do that, I want to create a little bit more negative overjet. This is negative overjet when there's a space there, because I'm likely to end up with tooth contact in the anterior. When I'm done, if the patient had this in reality, then I would go ahead and close that with some extrusive forces. So that's essentially what we came up with. Made this tooth unmovable, all the molars unmovable, and created as much alignment as I could with a little bit of space here to give me some freedom that when I'm done the active set of trays, in this case it's, let's see, this is treatment plan 3. Yeah, so this treatment plan here, 16 trays. I would then do some refinements to further close these spaces if they exist. My gut tells me you're actually going to have more contact than you think. And that just comes from experience with Invisalign. I did quite a bit of IPR in the lower. Let's dial that in. And I went all the way back to the first molar. This can be tricky to do. With that said, with the tools that we have, this is rather predictable. The goal in the end is to not have this space here. just to keep that in mind. So I would educate the patient that this is a case you're likely to have several rounds of refinement trays to get this perfect. This is, again, a rather difficult case, but I think this would be a great place to start. Educate the patient on the IPR, potential enamelplasty after you're done to kind of improve this anterior contact, flattening this canine, maybe making this look like a canine, this lateral here, things like that. In other words, there might be a lot of modifications in the end that her quote-unquote friends might not have. So I always try to set the stage for the end game of the process, rather than you're just having Invisalign. You're having Invisalign, which is a tool in the context of a much greater case. So let me know if that helps. I can assure you that there's many ways of approaching this case, but I wanted to share what my thought processes were with a case of this complexity. If you want to kind of introduce some more patient variables that might change how we approach this, happy to have that conversation. Good luck, Doc.